Good morning. My name is Susan Ryan. I am the Executive Director of the Center on Disability and Community Inclusion at the University of Vermont in Burlington, Vermont. Thank you so much for joining us today. And this is the second part in a two-part series on the topic of fetal alcohol spectrum disorders, the basics. So before we get started, we were going to do a quiz so that I could better understand who is on this webinar. So it's being launched right now. If you could take a couple of minutes and indicate who you are in those positions that are described right there. Okay, I'll give about 30 more seconds for anybody else online that would like to identify who you are. Okay, thank you very much. We'll move on to the next one. I have yet again one more poll for the purposes of the center that I work at. I would like to know if you are a professional or paraprofessional, family member, a legislator, or just a general public or community member. Okay, thank you so much for your willingness to do this, and we'll move right along. Okay, before we get started, I wanted to lay out some assumptions, at least that I come to the table with. The first assumption is that there's a person behind the diagnosis, or what we call the face of FAS or FASD. So that philosophy of a focus on the individual is something that runs underneath the whole conversation or whole presentation that we'll do today. And the second one is I wanted to put out some take-home messages or some points for you to think about and consider. And the first one is that there is no known amount of alcohol has been found to be safe to drink while pregnant. The second one is that people with FASD need lifelong supports. That's usually not well understood by professionals or the general population. The third is that the rate of FASD is as high as the rate of autism spectrum disorder. So one might ask the question, why aren't we doing anything about this CDC fact, the Center for Disease Control fact? And finally, a take-home message is that individuals who have FASD need prevention, diagnosis, intervention, and wraparound services. So I wanted to do just a very quick review of a couple of points that were brought up in the summer in the first FASD 101 series. And the points I want to talk about are fetal alcohol spectrum disorders, some facts about them, and the economic costs of FASD. So just by way of reminder, the diagnosis criteria for FAS includes maternal consumption of alcohol, documented facial abnormalities, which the three that are typically or statistically prevalent in individuals who have FAS are a smooth philtrum, which is the space between the nose and the mouth, a thin upper lip, and small palpebral fissures, which are the distance between the inside and the outside of the eye. A third diagnostic criteria is a documented growth deficiencies, and the fourth is documented central nervous system abnormalities. So let's take a look at the central nervous system abnormalities of FASD. So documentation of any of the following need to occur. So the physician or the dysmorphologist looks at the structural abnormalities, usually the head circumference of less than 10%. And clinical significant brain abnormalities via imaging. A second one is neurological damage, and the third one is functional deficits. So I shared, I think, this picture at the first webinar, and I just bring it up again so that you can see a visualization of the difference between a brain of a baby that was not prenatally exposed to alcohol, and that is on the right-hand side, and a brain of a baby that was prenatally exposed to alcohol. And this is a visual picture that's very dramatic for either trained individuals or even people on the street. They could see the damage that alcohol has on the developing fetus, particularly the brain area. So on this slide we often use to depict that fetal alcohol syndrome is just the tip of the iceberg. So that's what's exposed above the water, FAS. But FASDs, or fetal alcohol spectrum disorder, you can see that there is a lot more of this iceberg underneath the water. So FAS is just, as we said, the tip of the iceberg, and the number of individuals that fall within the spectrum are considered to 3 times that of FAS. So let me give you some other figures. Some other disadvantaged groups, such as American Indian or Alaska Native groups, and some other minorities, have FAS, the syndrome, as high as 3 to 5 cases in 1,000. Children in foster care, the statistics show that 15 cases per 1,000 have FASD. Youth and juvenile justice system, more than 200 individuals per 1,000 with FAS or related disorders. And other sources place the incidence at 9 to 10 per 1,000. So depending on who you're, what research you're looking at, you might find different numbers, but some estimates of FASD are as high as 1 in 100. People often do not receive a diagnosis, period, and often don't receive it early enough. So this slide is put here to depict the enormity of the issue of FASDs. And when we talk about just the syndrome, fetal alcohol syndrome is just a small fraction of the individuals who would be on the FASD spectrum. So again, so it's an umbrella term. FASD is an umbrella term, and it refers to the range of disorders or disabilities that can occur as a result of prenatal exposure, and it's not a diagnosis. Fetal alcohol syndrome is the diagnosis. So here are some other facts about fetal alcohol spectrum disorders. They're the leading cause, or the leading known cause, of preventable intellectual disabilities according to the CDC, that they affect an estimate of 40,000 newborn babies every year in the United States, that they're as common as autism. That was put on the CDC website at one point. That this next point I'd like to mention with particular emphasis is that the effects of FASD last a lifetime. They often are unseen by the eye, but the effects of the prenatal exposure to alcohol last a lifetime. People with FASD can grow, improve, and function well in life with proper supports. So here's some other facts about FASD. No known amount of alcohol consumption during pregnancy is proven to be safe, and FASD is not caused by the biological father's alcohol use, but the father can play an important role in helping the mother or the pregnant woman be alcohol-free during pregnancy. So here's another quiz. I just wanted to ask you, which teratogen has the greatest impact on the developing fetus? Wait for that to come up on your screen, and there you have it. Is it cocaine, heroin, alcohol, or marijuana? So yes, this is different than the first time I put the slide up in July. So yes, believe it or not, alcohol, of all these teratogens, including heroin, cocaine, and marijuana, has the greatest impact on the developing fetus. Okay. So the causes of FASD. All alcohol beverages are considered harmful. Some people believe that beer is less harmful than hard liquor or wine, but the research shows that any alcohol consumption is dangerous, and some research indicates that binge drinking is even more harmful. So here's some information on the economic costs of FAS. FAS, the syndrome alone, is estimated to cost the United States nearly $4 billion each year, and the average lifetime cost for a child with FAS is almost $3 million. One prevented case of FAS saves, and you can see the figures on your screen, more than $1 million in 30 years. So these slides speak to the economic cost of FASD and would lead one to think that prevention would be an important activity for a state. So if you prevent alcohol use, you prevent an individual ending up with fetal alcohol syndrome or fetal alcohol spectrum disorder. So the second part of today's section, I want to highlight two other aspects. Risks of not accurately identifying and treating FASDs and a trend in treatments. So here are some risks that are associated with not accurately identifying and treating FASD. The risk for the individual with fetal alcohol spectrum disorder is unemployment, loss of family, homelessness, jail, premature death, increased substance abuse, wrong treatment or intervention is used. Sometimes wrong treatment or intervention is used because people don't know that the individual actually has FASD, and they might be, quote, treating the individual with different medications that are effective with individuals with attention deficit hyperactivity disorder or other disorders, and not actually treating for the fetal alcohol spectrum disorder. So some of the other risks that are associated with FASD that affect the family or is a loss of family in general. Divorce, increase in substance abuse among the other family members, premature death, and financial strain and emotional strain. Factors associated with reduced life complications for individuals with FASD. So in other words, if any of these are present for a person with FASD, their success usually increases. We know that if an individual with FASD is in a stable home, and a stable home, 72% of that person's life, that the deleterious effects of alcohol are usually decreased. That's not always the case. I've worked with foster parents or adopted parents who have had who've provided a very stable home, and their adopted or foster child or young adult with FASD has gone on to have challenges, whether they be in school or in the community or in the criminal justice system. But stable home is typically looked at as being a mitigating factor for a person with FASD. Another factor that's associated with reducing life complications is early diagnosis. This is one that's stressed by the Center for Disease Control, many researchers, and many FASD projects. It's really important to diagnose early so that the individual can receive services and supports in school, and so that the family can receive wraparound services. A good quality home and basic needs being met at least for 13% of their life. So here are some trends in treatment. Strategies to assist people with FASD and their families continue to increase dynamically, in the last 10 years. And the Center for Disease Control, as well as the Substance Abuse and Mental Health Services Administration's Center for Excellence on FASD, provide a variety of materials for family providers and educators. And you'll have this slide. Vermont Family Network is going to post this, so you can find all these resources on being saved for you. In addition to other materials, there's FAS, which is the National Organization on Fetal Alcohol Spectrum Disorder, and again, the Center for Disease Control. If you just Google that, there's a wealth of information now coming together on diagnosis and prevention and wraparound services for people on the FASD spectrum. So moving into section 3, I wanted to talk about the importance of prevention and risk reduction. So what I'll share in this section is prevention starts with asking. Brief interventions can equal prevention. Public awareness messaging is very important. We can all talk about alcohol use. Who needs to know about FASDs? Raising awareness in schools or raising awareness in communities. And maybe this material will help you in your communities as you begin to share information on the needs of individuals with FASD and the importance of prevention. So prevention starts with asking. So many states have begun to work with OBGYNs in trying to put some of this prevention information in those doctors' offices. So ask all women of childbearing age about alcohol use. Ask routinely at every medical appointment. Ask at appointments in various systems. Ask in a non-judgmental way, of course. Use effective screening tools. Ask about possible prenatal exposure. And one way that people have found that this is effective is by embedding questions like this about alcohol use in the general health questions, wearing seatbelts, taking vitamins, smoking, etc. There's a number of screening tools that have been validated to use with general populations that include risky drinking behaviors, and some of these that for social workers, psychologists, physicians. They have used tests like the Short Michigan Alcohol Screening Test. They've used the CAGE, the Alcohol Use Disorders Identification Test, which is called the Audit. And CDC actually in 2009 has a publication entitled Reducing Alcohol Exposure Pregnancies, a report to the National Task Force on FAS and FAS and Fetal Alcohol Effects. Another aspect that's been found to help with prevention is brief intervention can equal prevention. And research shows that brief interventions can help reduce alcohol use among women of childbearing age, whether pregnant or non-pregnant. Brief interventions include outreach, screening, referral, and other activities that promote health of the mother and among pregnant women, the fetus. So brief interventions have been effectively implemented by health professions in primary care, in emergency situations, in substance abuse treatment centers, and also on university campuses. So, brief interventions in control studies have produced positive results and recommended brief interventions in motivational interviewing as effective approaches to be used when intervening with pregnant women. In primary care settings, researchers who were Whitcomb and his colleagues in 2004 reviewed 12 trials of the efficiency of behavioral consulting interventions in primary care to reduce at-risk or harmful alcohol use by adults. And the results indicated that participants in the experimental groups reduced their average number of drinks per week by 13 to 34%. That was greater than participating in the control studies. So the concept of prevention and asking and motivational interviewing has been found to be effective in helping people think about the impact of alcohol on the developing fetus. So this slide, produced by the Minnesota State Department of Education, is a good poster that they use for some of their prevention campaigns. And now is a good time to stop drinking. We can all talk about alcohol use, talk about the effects of alcohol on the individual and the fetus, begin at an early age. Some states are implementing these kinds of conversations in elementary schools. In Alaska, where I worked for 25 years, I mentioned some of that work in July, but my experience is that to get in there at the 5th and 6th grade level to talk with students about that, because oftentimes by 7th and 8th grade, at least in rural Alaska, individuals are experimenting with alcohol and other substances. So talking early to elementary school children, also embedded in the curriculum of just wellness and healthy living, has been found to be effective. Also, the father can play, as I said, a really important role in preventing FASD by helping the mother avoid alcohol. And also indicate that stopping drinking at any time during pregnancy will help the fetus. We can all talk about it, convey the message to women, say no, no alcohol for you and for your baby. So who needs to know? In general, we want to put out the message that everybody needs to know, because everybody has a role in this, because it's a public health and a community issue. The Center for Disability and Community Inclusion at UVM, where I work, collaborated with the Howard Center on February 9th, which was International FASD Day, and we put on a symposium at the courthouse that we called FASD in the courts, where we're trying to improve people's understanding about FASDs, and we had judges and attorneys and other people involved in the criminal justice system there. We also had a judge from Barrow, Alaska, linked in via the telephone, so he did a bit of a presentation. But that was just one attempt at getting information out on FASD. The Vermont ADAP folks have started a prevention campaign. They have posters that they're distributing to their regional ADAP providers, where they're trying to get the word out that alcohol use during pregnancy should be avoided, and the word out on FASDs in general. So we believe that everybody needs to know about this disorder. Also, there, as I mentioned, there could or should be awareness raised in schools, in elementary schools, and it can be included in healthcare or science or physical education classes. Assemblies can be put together in the elementary or the high schools to talk about and to increase awareness of FASD. So the American Indian Institute has a curriculum and awareness campaigns that they're putting in their school. FACE is yet to come for middle schools is what their campaign is called, and Remember What You Know for high school students. Here's in general, raise awareness in the community, post FASD information in doctor's office, treatment centers, community centers, promote FASD Day, which is every year, September 9th. Visit the FASD Day website. Discuss FASDs in your community, at work, church, anywhere. Awareness can have a positive impact on everyone. So again, here are some of the other resources that will be on the webinar that's saved for you. So this is just a conclusion to this particular section that talks about the benefits of identification and the treatments of FASD and what is needed. So the benefits of identification and treatment of FASD: it helps decrease anger and frustration for individuals, families, and providers and communities by helping them understand that negative behavior results from disability and is not willful. Helps people with FASD succeed by focusing on their strengths and what will help them, not on their weaknesses and what they've done wrong. Helps improve outcomes, helps prevent future births of children with FASD. So we believe that it's important to identify and provide support and treatment for FASD. We believe that what is needed to adequately address FASD is a paradigm shift. We must move from viewing the individual as failing if he or she does not do well in a program to viewing the program as not providing for the individual needs in order to succeed. Here are some other facts about FASD. The IQ of somebody that has fetal alcohol syndrome is generally, the average is generally 60, but it's a range from 20 to 110. There's poor judgment or decision making, problems with behavior, social intervention, motor skills. They might have physical abnormalities, I've worked myself as an early interventionist in Alaska with babies that have had significant severe disabilities as a result of prenatal exposure to alcohol. So they have had feeding challenges, motor challenges, delays in the ability to sit up, crawl, walk. I've worked with individuals in elementary school who are struggling academically, who typically fall right a couple of years behind their peers in academics. I've worked with individuals at 19 to 21 who have had multiple interactions with originally the juvenile justice system and then later with the criminal justice system. So the lifelong effects of prenatal exposure to alcohol are significant, and it is a disorder that must be addressed by multiple interdisciplinary personnel, such as, including physicians and psychologists for diagnosis purposes, but also special educators and regular educators as young children move into the school system from 3 through 21, and then as they transition into adulthood. So this is a disability that really affects an individual from birth to death. And it's, in my mind, a disability that is not really on the radar. These individuals often fall through the cracks. And it really will take a state to have in a sense, a systems approach to this disability. So this is some information I think I shared in July also, but I wanted to underscore again today. This is Strijsguth's research. Anne Strijsguth from the University of Washington. They have a clinic, one of the leading clinics in FASD and at the University of Washington. And she followed 415 of her patients. And in 1996, as well as 2004, she republished this information in 2004. These are the results of the individuals that she followed that were in her clinic, 415 of them. 94% had mental health disorders, and 23% of those had mental illness that required inpatient care. 83% of the adults experienced dependent living, so had to live with either their parents or some sort of community residential facility. 79% of the adults have employment problems, meaning that they had difficulty keeping a job, getting a job. 60% had trouble with the law. 50% had confinement as defined by jail or prison terms. 61% had disturbances in school experiences, and the students I worked with in Alaska, they had their story was that they often came in and out of class, either dropped out, ran away, or went to increasing different residential school facilities. 35% of adults or adolescents have alcohol or drug use. So these statistics are really troubling, and you want to ask the question, what are we doing for our young children and young adults or adults with FASD? And again, this disability affects the family, it affects the school, it affects the community, and certainly it affects the individual with FASD. And these data are why we must do something. And it's really a systems approach. Prevention, diagnosis, intervention, and wraparound services. So as you can imagine, this would require the involvement of multiple programs. So again, identifying FASD helps. Early intervention is critical. Protective factors, as I mentioned before, are helpful. Knowing this is important as we begin to diagnose an individual with FAS or being on the spectrum and begin to provide supports to them. Case management is required across the lifespan. The number of individuals, professionals or paraprofessionals that come in and out of the lives of people who have disabilities is well known. We all know that. And the number of individuals that come in and out of the lives of an individual with FASD is staggering also. And the more that we can put supports in place to the family and to provide consistent case management and support and services, the better life outcomes for an individual with FASD. Here's a list of some of the case managements that an individual with FASD might need. Medical and health care, early intervention and education, proactive mental health services, increased supervision through adolescence and early adulthood. I'm going to stop there. There is at least 1 or 2 programs in Alaska that's trying a mentorship program. So in other words, like a big brother, big sister. So somebody that would be able to have a regular connection with the male or female, the girl or boy, to be able to support them in life decisions, because we know that individuals with FASD have challenges in judgment and decision making and executive functioning skills. So somebody that is their friend, is a mentor who has a consistent involvement in their life, those kinds of interventions have been found to be helpful for an individual with FASD. Proactive preparation for adulthood, the many complexities of being an adult, getting a job, holding down the job, going to school, having a family, caring for others in your life. And then if an individual ends up in juvenile justice or the correctional assistance, that those individuals need training. The people involved in juvenile justice and correction need training, as well as the individual with FASD. If they go in and out of the juvenile justice system, they need proper supports for transitioning back into the community. So the next section, and this is the final section, I wanted to highlight some Center for Disease Control Intervention studies that are being done. In other words, that CDC has funded these 5 studies. And this is just a broad brush introduction for you of those studies. So there's a study that's being done at the University of California in Los Angeles. They call it the Friendship Study, or really the Project Bruin Buddies. And it's about teaching friendships. Many children with FASD have difficulty making friends, keeping friends, and engaging in social interactions with others. We know that social competence, social emotional competence is a challenge for the young children with FASD and with all the way up to adults. So they're doing this friendship study. This type of training teaches a variety of skills to individuals with FASD, including how to interact with friends, how to enter a group of friends already playing with each other, to help with in-home play dates, and ways to avoid conflict and use negotiation skills. They're doing this study with young children, I think between the ages of 7 and 10. And the evaluation of the study is showing that it's increasing social skills and decreasing problem behavior. So this is an exciting study that CDC has funded out of the University of California. The next study is actually being done at the Marcus Autism Center in Atlanta, Georgia. So they are, because we know that individuals with FASD often have challenges with math, and so these researchers wanted to use a specialized math tutoring program. Special teaching methods and materials can help improve math knowledge and skills in children with FASD. So this research study that was called MATH, Interactive Learning Experiences, evaluated this type of training and found that it can greatly improve a person's math skills. So that's just one of the academic areas, as you know, in elementary and high school. And so this is just beginning research on one type of intervention to improve one area of academic success for individuals with FASD. A third intervention study that's being funded by CDC is happening in Chicago at the Children's Research Triangle. And it's focusing on the general area of executive functioning training. This type of training teaches behavior awareness, self-control, improves executive functioning skills such as memory, cause and effect, reasoning, planning, and problem solving. The research study evaluated this type of training and found that children with had significant improvements in effective functioning skills in the area of memory, cause and effect, and problem solving. So this is also an exciting study because this is one of the major challenges of individuals on the FASD spectrum, their challenge with executive functioning. The next study I wanted to share is from the University of Oklahoma Health Services, and it's a parent-child interaction therapy. This type of therapy is intended to improve parent-child relationships, create a positive discipline program, and reduce behavior problems in the child with FASDs. Parents learn new skills from a coach, and a couple of programs across the United States are trying this, and just the concept of increasing interactions and positive interactions between the parent and child. As you can see, most of these funded studies are about children. And lastly, I wanted to share with you research that's being done at the University of Washington. And as I mentioned before, UW has done some of the seminal work in FASD. First, Ann Stryguth, who did the early work on diagnosis and ran clinics. And then Susan Ashley has done an extensive research on what they call the 4-digit code, which is the diagnostic criteria for identifying FAS, fetal alcohol syndrome. And then there's a number of different individuals working out of UW that are doing support and research. And this one, children with FASD can have a variety of behavior and learning problems, which can lead to high stress for families. And Heather Carmichael is running this program as Families Moving Forward, and working with families and caregivers to improve their ability to support their child with FASD and to reduce child behaviors. So these are just a couple of the CDC-funded interventions. But what needs to happen in Vermont is a link system approach, a system of care approach that we've done so effectively for other disabilities. We need a strong prevention campaign that, again, ADEP is starting so that people in general are aware of this, aware that prenatal exposure to alcohol is harmful, that no known amount is found to be safe. And so we need a strong behavior campaign. Posters, television, ads, presentations at schools, at community centers. We need diagnostic clinics. We need to have physicians who are able to identify and diagnose fetal alcohol syndrome. And we have several of them in Vermont right now. Leah Burke is one of them, and she works in a clinic in Burlington. We need interagency collaborations on wraparound services. So again, this is an interagency issue. We need education, working with mental health, working with health department, working with the criminal justice or juvenile justice system. So it's a disability that cuts across a lot of people's expertise, and we need that expertise. We need behavior specialists, we need family support, we need training and technical assistance, and again, we need coaches, big brothers, big sisters, or a mentoring program for young adults with FASD. So I'm going to take a look at the questions that are posted up on the board right now. So there's a question here, are the good results of a stable home because the brain is healing? The good results of a stable home occur because of the consistency and the reliability that the home provides for an individual with disabilities. So if they are in the same home for an extended period of time, they have a greater opportunity to learn skills, learn routines, learn, and things that can help them as they get older. So not because the brain is healing. The damage that has been done by alcohol to the brain is static in a sense. So the next question is, would a diagnosis of FASD be a mitigating factor in sentencing a youthful offender? That's a great question. And so first of all, I just wanted to just say that just please remember that the fetal alcohol syndrome is the diagnosis and FASD is the spectrum disorder. So, but yes, there's, as I mentioned, that we put on a symposium in Burlington, and we linked in a superior judge from Barrow, Alaska, who he was involved with helping that state get a law passed that involved that courts could consider a mitigating factor of prenatal exposure to alcohol in sentencing either a youth or an adult. And he described that knowing that the individual had prenatal exposure to alcohol, and whether it was diagnosed or not, could be used in the state of Alaska for mitigating or an alternative sentencing. So that's a great question. I'm not sure of any other states besides Alaska that has that, and that's just passed recently last year. The next question is, do you know if programs like the Lund Center require pregnant women to take urine tests so that alcohol use does not occur? I don't know. Okay, the next question is, do you know how the rate of FASDs in the U.S. compare with other countries where reliable statistics are available? Again, excellent question. So when I worked in Alaska for 25 years, and one of the reports that came out in, I think, about 2000 was published by the Morbidity and Mortality Weekly Review, and that placed Alaska and Alaska natives as having one of the highest rates, reported rates of fetal alcohol syndrome and fetal alcohol spectrum disorder. And we could ask whether or not that was because Alaska was doing a great job with diagnosis and identification, or we could question whether or not Alaska did in fact have a higher rate of FASD. So clearly where countries or states are doing this surveillance or prevention or diagnosis, the numbers are higher. But there's also some research that's out of South Africa that has indicated that there's a high rate of FAS because in some of the vineyards down there, the individuals were actually being, the people that were working those vineyards were actually given wine as payment. So the people that report on that research say that there's a higher rate of FASD there. Ireland, I did a Fulbright there in 2004 and 2005, and they have a reported higher rate of FAS also. So yes, it would follow that if a state or a country is doing a surveillance program, that you might see that the numbers have increased. Canada's ahead of the United States in many ways with prevention campaigns, with doing surveillance, with doing diagnosis and treatments, and so they have published various studies that have indicated that in their First Nation communities that FASD is higher. But one of the take-home messages that I'd like to give, and that others who talk about FASD give, is that it's in a sense an equal opportunity disorder. Is if you drink, then you have a higher chance of having a child with FAS or FASD. So, and that it cuts across economic class. It's not a disability that's just for people of low income, that it's not a disability of just a certain ethnic group. So, so that's a take-home message. Here's a question. If the facial features are very mild, yet all the other elements are present for FAS, would FAS be diagnosed? You say it is often not diagnosed. Why? If one of the main things is that the face is the face, wouldn't that make it fairly easy to diagnose? That's a great question too. So here's the issue with the face. The physical phenotype of FASD, meaning the physical facial features of a thin upper lip or a flat philtrum or a small palpebral fissures, that often goes away as the individual gets older. So the face is not always picked up if somebody is diagnosed later. So so some researchers, some diagnosticians have actually asked people to bring pictures of them, or have the parents bring pictures of the child when they were younger. So okay. Here's a question. Would neglect or malnutrition in early childhood produce similar effects on a child as FASD? That's not a question I feel comfortable answering, but what I could say is that in the situation where somebody is using alcohol or abusing alcohol when they're pregnant and they have poor nutrition, then there's some research that shows that that combination has a greater likelihood of the child having FASD. On the flip side, if there's better nutrition, that might mitigate some of the more significant outcomes of FASD. So nutrition is very important obviously for the woman that's pregnant and for her developing child. And so let me see if I might take one more question. There have been some national campaigns recently about the negative effects of smoking. Are there any organizations that are planning national campaigns that would address the effects of alcohol in developing fetuses? Yes, for sure. As I said, the NOFAS, which is the National Organization for Fetal Alcohol Syndrome, has a national campaign, and some other states have very strong FAS and FASD campaigns. And as I said, the Center for Disease Control and SAMHSA has initiated every September 9th to be International FASD Day. So, okay, maybe one more question. Can an adoptive parent who is considering adopting from a country in the former Soviet Union, where there can be a high rate of alcohol use, have an infant checked for FASD before moving forward with the adoption? That's a great question. When somebody else had asked about countries that have a high rate, we believe that the rates are higher in with the old Soviet bloc countries. So because there's a higher rate of alcohol consumption during pregnancy. And yes, one of the things that have helped beginning to put FASD sort of on people's radar is the parents that are adopting children from Russia or the Ukraine or Romania, and are not finding out until they come to the United States, and not often until the child might be 5, 6, 7, that they A, have been prenatally exposed to alcohol, or B, have FASD. So can the parent who is adopting a child have the child checked for FASD? They can do that. There are people in those countries that are aware of FASD. Now, whether the adoption agency can help facilitate that, but I have heard that adoptive parents have done that. So I want to. Okay. Oh, yeah, so somebody followed up with that and said, so in the case of international or foster adoptions, we may not have pictures of children when they were young. Is a face so required for diagnosis? How can we go about getting a diagnosis when we believe it is FASD? I would say start with your family physician and ask them, tell them that you you're wondering about that, and if they can help you find somebody who might be able to provide a diagnosis. So yes, they can provide usually reported maternal report of consumption. That's usually good to have for a diagnosis. So whether it's if it's a question, or if the adoption agency might have more information about the mother that you can obtain to be able to share that with the physician, that might be good. But there are many tools out there for screening for FAS. And the one that I was trained on was called the 4-digit code from the University of Washington, but there are many others. And so just maybe I left my email on one of the last slides, and you're welcome to email me, and I could help send some information to you that you might want to share with your physician, or also share with you the names of some people in Vermont who might be really helpful as you move forward. Any parent that might be online. Feel free to email me at susan.ryan@uvm.edu. Oh, so we have one last quiz that I also need my report. We have a database at the University of Vermont, the Center on Disability and Community Inclusion. If you could just rate your satisfaction with this presentation, as I was satisfied with this presentation. Yeah. Well, and I thank you very much for coming on today. And if you are interested in this area, please email me. The number of projects in the state of Vermont are very low at this time, and there's a group of people that are interested in helping change that. So thank you very much, and thank you to Vermont Family Network for joining us today at this webinar. The webinar will be archived on the Vermont Family Network's website, along with many other previously recorded webinars that you might be interested in. So be sure to visit Vermont Family Network, who is a great source of support and information for families. And for a complete list of upcoming webinars and workshops and support groups, you can find them on their website. Thank you so much today. Goodbye.